Hello, I'm Patty Pellikka, Editor-in-Chief of Journal of the American Society of Echocardiography. Welcome to Author's Spotlight for the month of May. The May issue of JASE is on precision imaging in echocardiography. Quantitative echo has an important role in personalizing medicine, and the entire May issue is about the precision of echo measurements and novel applications of echo in understanding various disease phenotypes. I have with me today the lead author of a paper in this issue, Dr. Minh Nguyen, and his paper is entitled Modeling the Relationship Between Diastolic Phenotype and Outcomes in Pediatric Hypertrophic Cardiomyopathy. Welcome, Minh. Tell us a little bit about yourself.
Hey, Dr. Pellikka. It's an honor to be here. Thanks for having me. So I'm a pediatric cardiologist based in Houston. I did my medical training in the Bronx, a pediatric cardiology fellowship at Children's Hospital of Los Angeles, and then a research echo fellowship at the Hospital for Sick Children in Toronto. Personally, we moved to Houston 2 years ago, and we've been having a lot of fun exploring the city. It's a very big city. Finding places to eat and spending time with their kids.
Thanks for joining us. I really loved your paper. Tell me what inspired you to do this study.
Yeah. I've been interested and fascinated about diastolic function since I was a pediatric cardiology fellow. It was a really nice opportunity to marry physiology to imaging findings. And when it worked in the clinical context, it was very satisfying. Now, as you know, it doesn't work all that consistent in children, unfortunately. So when I did my research echo fellowship, I had the opportunity to explore that a lot more. So I joined a ultra-fast ultrasound research lab run by Olivier Villemin. And we were able to do some very novel things like understand myocardial stiffness using shear wave elastography in the heart. And I also was part of the clinical research echo lab where I got to learn from Luke Mertens, Mark Friedberg, and Andrea Jaglescu about how to use conventional parameters and do research on them. So from there, those experiences developed a narrative review paper on pediatric hypertrophic cardiomyopathy, exploring how phenotypes within peds HCM could be linked between genotype and outcomes a little bit more. And diastolic function was obviously one of those things. And this paper was an exploration of that topic.
Great. You used a really interesting form of analysis, your principal component analysis in this study. Tell us a little bit about that.
Principal components analysis is a statistical method that is employed in a lot of high throughput research, like in genomics. And we thought it'd be an interesting opportunity to use it here to address some of the issues with diastolic function research. So perhaps I could show you a couple of slides, a little background just to get everyone on the same page about the paper. As we all know from the evidence that echo diastolic function parameters are associated with adverse events in pediatric hypertrophic cardiomyopathy. Two pretty prominent clinical risk stratification tools for pediatric HCM that recently came out use certain echo parameters for diastolic function, like the HCM risk kids score, as well as the primacy tool. And but the one thing that we wanted to explore more was how do these big players in pediatric HCM, like genetic variation and ventricular hypertrophy, affect diastolic function's impact on outcomes? So to do that, we had a data set of 84 pediatric HCM patients, had a baseline echo with diastolic function parameters and a bunch of other parameters like ventricular thickness. And they were all part of that primacy registry, which had very granular genetic and adverse events information. The issue with diastolic function research is that it's very challenging to characterize for a lot of different reasons. One of the big ones is that there are multiple unseen variables that impact changes in diastolic function parameters. Now, we want things like active relaxation and chamber stiffness to impact those changes, but other things do too. For example, diastolic function parameters are dynamic or vary a lot in a normal child. And the other is that children develop diastolic dysfunction differently than adults. For example, not every child will have delayed relaxation imaging phenotypes who have pediatric HCM. Sometimes they just have restrictive patterns. There are several diastolic function parameters to choose from as well. And there's unclear interactions between the variables. And there's multiple redundant parameters, as you all know, like E prime, medial, and lateral. I mean, they're technically different, but they describe a very similar process. So how does PCA help with these issues? Well, for the issue of several diastolic function parameters to choose from, we found that PCA can summarize highly correlated variables into one variable. In terms of this multiple unseen variables that impact changes in diastolic function parameters, well, PCA separates groups of variables as independently as possible. So each summary variable tries to represent a distinct variation in that data. To help us understand that a little bit more, because that was just like a ton of words, I have a toy data set I made up. So there, let's just say we have a group of patients with elevated heart rates. One of them had a diagnosis with SVT, and the other group had a diagnosis with sepsis. We collected a lot of different we collected a group of variables in each patient. So temperature, CRP, number of blood cultures, number of ECGs, frequency of adenosine given, and beta blocker use. And the question we had was, how are these variables related to each other? Well, here's our data set, and patients are on the rows, and then the variables are on the column. And you can see already that patients that have high temperature also have high CRP and high number of blood cultures. And when they don't have that high temperature, CRP, or blood culture, so when they're blue, they all go down together and they all go up together. So this high correlation between these variables, PCA can see. And PCA will then essentially make a summary variable that says all the variation that's seen in these variables is represented in this new variable called principal component 1. Now, if you look at number of ECG, adenosine, and beta blocker, you can see that they don't correlate that well with temperature, CRP, and blood culture, but they do correlate with each other. So when you have a high number of ECGs, you also have a lot of adenosine was given and beta blocker usage. And so PCA sees that. It sees that there is a difference between temp, CRP, blood culture, and ECG, adenosine, beta blocker. And it says that, hey, let's make the variation seen in these three variables another principal component called principal component 2. Now, the way we can study how principal components analysis organizes these variables is by looking at an impact score that each variable has, also called a loading. So PCA will essentially pop out a little table, and it'll tell you how important each variable is in the variation of the new summary variable. So temperature, CRP, and blood culture have high scores, principal or loading scores, while ECG, adenosine, and beta blocker have low scores for principal component 1, and vice versa for principal component 2. Now, this is kind of hard to see in a table, but it makes it much easier to understand if you visualize it in a plot. So we have the loading scores or the impact scores for principal component 1 in the x-axis and 2 in the y-axis. And you can see that CRP, temperature, and blood cultures have a very high principal component 1 loading score, but a low 2 score. And if you take a step back and look at what PC1 might represent, I would argue it could represent diagnostic tools for sepsis. Conversely, principal component 2 probably represents diagnostic tools for SVT. Now, let's say we measured a bunch of other variables that had nothing to do with diagnosing SVT or sepsis, like how many rhubarb pies you ate that day. Well, then it would have a very low principal component loading score for 1 and 2. Just to kind of bring all of this explanation into context, I just wanted to show you guys the loading plot for, just forgot to say, so just in summary, highly correlated variables have similar scores, and principal component analysis summarizes those variables into clinically interpretable groups. So to kind of bring that into the context of the paper, let's look at the loadings plot in our paper. Very complicated, very busy because we had 34 variable echo variables, but I did some things to help us out. So one is that for principal component 1, the variables that had a high loading score in this PC1 is in red. And if I could just walk you through it real quick, you can see that E prime, LA conduit strain, LA reservoir strain, they're all in there. And if they have a high similar loading score, they should correlate well. And that makes sense, right? When you have a low E prime, you'll have a low conduit strain, you have a low reservoir strain. Now look over here, and you can see these variables are red too, but they're negative values. And all that simply means is that when you have a high E to E prime ratio, you'll have a low E prime ratio, or a low E prime, which also makes sense. And if I were to take a step back and look at what all these red variables represent, I would say that principal component 1 might best represent echo variables that estimate LV filling pressure. Now, if you look at principal component 2, the highest scores are in green, and immediately you see a pattern there. Mitral A wave, LA booster strain, A prime, these all represent LA contraction parameters. And one thing I just wanted to note is that we have a bunch of other variables here that don't have high loading scores. 2 that I want to bring out to you is LA diameter Z score and index LA volume, which are big players in diastolic function measurements. Spoiler alert, that's the third principal component. So I hope that PCA explainer helped, and I hope that looking at this plot together makes you guys more interested in reading the paper.
Very elegant analysis. Was there anything in particular that surprised you?
One of the things that really, I remember when I first plotted this loadings plot here, it was really cool to see that PCA was able to separate or kind of distinguish that there was 2 clinically relevant parameters that could be embedded in the data. The fact that it saw that left atrial contraction moved differently than LV filling pressures, I thought was very, very interesting. One, because it made clinical sense. You know, we know that those things tend to vary differently from each other. And 2 is that it helps us prove that more in our own data set. Having the ability to summarize that type of variation and be able to say that there's just 2 big variables that we can talk about makes it much easier to explore the clinical context and do further advanced analysis.
Great study. Thanks again for visiting with me, Dr. Nguyen. And readers, check out the entire issue and let me know what you think of it. Thanks.